Okay, so we get to have an exciting little event now. I don't know if, Bhaskar, I see you. Can you hear me?
Yeah, I can hear you, Alex.
Thank you. That's a great thumbs up.
Okay.
So we'll do a quick introduction. So Dr. Bhaskar Purushottam, he's been with us for, 9-10 years now, Bhaskar?
Fetal Pro. Yeah, just over 9 years.
Just over 9 years. Little academic introduction. He's originally from India, did Bangalore Medical College, and then he did some time in New Zealand doing internal medicine. Briefly played around with the idea of cardiovascular surgery, which isn't surprising once you get to know him. Then ended up at cardiovascular medicine in Philadelphia, and ultimately William Beaumont in Michigan. Then he finally completed his training at Mount Sinai in New York. Came here in 2015, board certified in cardiology, vascular disease. He's the first doctor in the United States, I didn't even know that, to use a drug-coated balloon in the lower extremities. He implanted an Impella RP for the right side of the heart. We always brag about how we did that before Rochester. So
straight.
He's involved in a lot of research that we're doing. He's the director of our research department right now for the medical director. He's also the cath lab medical director. He's been involved a lot with the medical students, doing oral presentations, oral research abstracts. And he still goes back to New York and gives a talk periodically on interesting cases. And I think he's been over to Leipzig, Germany. Certainly not quite to the level of travel that Dr. Pollack has done. She was just telling me she's gone to Dubai and all these kind of places. But Bhaskar is definitely making a name for Rapid City, and we appreciate him very much. Bhaskar, do you want to give me an introduction here?
Yeah. Thanks, Alex, for the kind introduction. And I think I missed Dr. Pollack's lecture because I know that must have been phenomenal, and it's a nice segue to what we're doing right now. So, but first of all, I want to thank a couple of people. I think CC has been on the ground. We're trying to get this live case going on for the last maybe 2 to 3 years. So with all the legalities, so thank you, CC. And then the other person I want to thank is my lovely nurse, Ashley. I think been troubleshooting this, talking to different patients, and finally our lovely patient agreed for this live case. And then with that, I want to introduce my team. On my right is Marcy Dodge. She's the cath lab supervisor and the chief tech. So she's kind of like my wingman. So Marcy, you want to say in a few words what your role is?
Yeah, I am here to assist Dr. Bhaskar and help hand and wires the equipment that we need, running the equipment and make sure that the procedure runs smoothly.
Absolutely. I think she plays a very, very important role because, we got multiple eyes looking at the patient, the hemodynamics, the actual procedure. And then I don't know if you can see Shane in the picture. Shane, you want to come over to the side? So Shane, that's Shane. He's our really experienced, intelligent nurse. So he plays the role of watching the patient's hemos, giving the medicines. So therefore, we make sure that everything's on target and we never lose sight of patient safety. And then we have, on the next to Shane, we have Mary Schumacher, who will probably come into the screen. She's also a very experienced closer. There you go. Phenomenal nurse. So they all really keep a close eye on the patient. So therefore, when I'm focused on the procedure, you can sometimes get lost in the nitty-gritties. So therefore, it's very, very critical to have them. And then they also monitor, they kind of document things. And they also kind of oversee what's happening. So something's not right, they point it out. And then on my left is Tanner. He's a CRNA. So he makes sure the patient is totally comfortable and also watches on the hemodynamics. So that is our team. So let me, can we pull up our slides, guys? So I'm going to introduce the patient's details. There you go. Yeah, next slide. So those are my disclosures. Next. Yeah, so we have a wonderful lady, 59-year-old, who works in our local school, and she's got all the risk factors for atherosclerosis, which I'm sure you've heard in the morning talk. Her examination when I saw her in the clinic is pretty stable. So the reason she came to me was she's been dealing with lifestyle limiting left lower extremity claudication for the last year or so. She's been on exercise therapy, structured exercise therapy at home. She also was started on silastazole. That kind of didn't go well with the COPD and the breathing. So eventually, unfortunately, she started to develop nocturnal ischemic rest pain. So that's a condition when your blood flow is so poor and you lift your lower extremities up and things work against you because of gravity, your blood flow is reduced and you tend to have a lot more pain at rest. So when I examined the left PT pulse is completely absent. The left great toe has a very dusky appearance with a very weakly dopperable left DP. So those are our meds and those are our labs. So she's on good medical therapy. Next slide, please. So these are ABIs. I apologize for the real tiny slide. So pretty diminished on the left at 0.6. Next slide. Click on it, please. So this is the ultrasound. Essentially, as you can go from your left top hand corner all the way down to the right. You see those peak elevated velocities. Those are the ones in the left distal SAV, which said the stenosis was really severe. Go next. Next slide. Yeah. And then you can see those waves. They look really dampened. That's because it's hemodynamically quite significant. It's therefore suggestive that the stenosis is pretty nasty. Next slide. Yeah. So this is, go back. So this is a summary. So as you can see, Dr. Shaba read this ultrasound, so it has to be 100% accurate. So in summary, we have a 59-year-old woman with multiple risk factors for systemic atherosclerosis who presents to us with progressive left lower extremity claudication, which unfortunately now has gone into nocturnal ischemic rest pain with objective evidence of multi-level lower extremity arterial disease. So this is the very definition of chronic limb-threatening ischemia. And Rutherford has got categories 1 through 6. They objectively try to assess the amount of ischemia as well as what symptoms, mainly clinically driven. And 1, 2, and 3 is claudication. 4 is rest pain. 5 and 6 is bad ulcers. So with that, I'll show you what we did. So I don't know if the camera can focus right up here. So I think you have to move the eye back. Yeah. So what I accessed is I accessed the right groin right here. Right here, yeah. So where my fingers are pointing, that's the head end. And now it's pointing down to the feet end. So the sheath is inserted into the right common femoral artery under ultrasound guidance. And this is what happens. So you can see the fluoro. Let's switch to fluoro, guys. Yeah, so there you see that's the needle and that's the wire exiting. So we use a micropuncture technique. We use ultrasound guidance. The idea is to get access within a precision of 1 to 2 millimeters. Very, very critical. So then that's the catheter which goes up into the distal abdominal aorta. And then we take a picture looking at the aortoiliac bifurcation and how the blood flow is. And there you can see right up top, that's the main trunk. The abdominal aorta on the right is the right common and the left common iliac. So, and then what we do is we lodge the catheter at the bifurcation, and then we try to finagle the wire into the external iliac and the common femoral. So here you can see it's trying to go into the internal. So I position my wire, bring my catheter, pull my wire back, make a little turn, and then kind of advance the wire into the external iliac. So there it goes. Then I bring my catheter over and we take pictures. So this is the picture of the left femoropelvic arterial system. So let me see. You guys can see my hand on the, yeah. So this is the common femoral artery here. This other robust artery is the profunda femoris. And this is the superficial femoral. It's supposed to be at least as thick and juicy as the profunda, but you can see it's pretty skinny. And you can notice that right here, the flow is obstructed. And this is often the case, when the ultrasound is done, they say it's severe stenosis, but unfortunately, due to a lot of issues, by the time the patient gets to us, now it's turned out to be an occlusion. And it's kind of obstructed in the mid SFA. And then this is the flow in the distal SFA. So basically from the mid thigh to the knee joint. Yeah. And you can see, Marcy, show them the occlusion. So that's the occlusion. which runs from the mid SFA all the way down to the distal SFA, which is the Hunter's Canal, which is a tricky spot because that's where when you bend your knee, all the torsion and flexion is transmitted right down there. So next picture. So then we take pictures below the knee. So below the knee, ideally you should have 3 arteries running all the way down to the foot. So you can see there is kind of 3 of them, but they don't seem to be continuous. A lot of disconnections. So one of the problems here we also see below the knee is this artery is occluded right here. That's the anterior tibial artery. And this is the tibioperoneal trunk right here. Then this one is the posterior tibial artery. And this is the peroneal artery. And then we take the picture all the way down to the foot. So ideally in the foot, you got to have 3 good highways running, creating the pedal arch. And unfortunately, this patient has a proximal anterior tibial artery, CTO as the ultrasound identified, and the posterior tibial is occluded distally. And the peroneal is the one just, giving the collaterals. So, yeah. Now I want to show you the ultrasound. This is a new concept called pedal acceleration time. Can we focus on the ultrasound, guys? Can we do a PW on the DP there? Yeah. Yeah, there you go. So that's the dorsalis pedis. And by the way, Jennifer is our ultrasound tech. And so she's going to be the GPS. Yeah. So what you're seeing here is, can you get a PW? Yeah, right there. So you can see this waveform is so sluggish. And pedal acceleration time is the time taken for the blood flow to achieve peak systolic velocity. So the smaller it is, like roughly less than 100 milliseconds is good, but here it takes a really long time, therefore suggestive of very bad ischemia. So thanks, Jennifer. So next what we're going to do is we're going to cross this occlusion. You're good, you can take a break back. Yeah.
Take a break.
Yeah, you can go back. You don't have to stand here. Yeah. So what we try to do is people who don't need to be near the X-ray, we tell them to, stand away because radiation is not benign. That's the way it is. Yeah. And so what we're doing is we're lining up the camera and we're going to cross this blockage for you live. Back up one more. And this root. So we take a picture and we got to get through that occlusion. So you'll see my catheter there. I got a torque on this stiffs. So we have different kinds of catheters, different sizes. I also forgot to introduce 2 of my other phenomenal staff here. We have Jake. He is a nurse. And next to Jake is Kristen. So really, really good tech.
They can't see you if you don't come over here.
You guys have to come over. Okay. So what I'm trying to do is I'm trying to get my catheter right there. See, I got my catheter into the SFA. You can see that moving. Yeah. Marcy, hold my catheter. So there's Marcy. So we kind of play tango here to get through the blockage. So there's my catheter. And now I introduce my wire. Let's pull the catheter back a touch. Yeah, right there. So what I'm trying to do is find the entrance of the chronic total occlusion. And Alex, you guys are welcome to ask me questions. And there you see, that's my wire going through the occlusion. And a lot of it is based on the feel, on how I feel it's going through the blockage, 1. Number 2, I also look at the anatomy. Yeah, advance the catheter. So I pin my wire and the catheter comes over as a rail right there. Perfect. And depending on how the occlusion looks, I decide what kind of catheter, what kind of wires I should use. And here we'll take another map here to figure out. Angel Max is in, right, guys? Wonderful. So what I just asked was make sure the patient's anticoagulation. So there's the occlusion I have to get through. And you can see my catheter up top. And that's my wire. Beautiful. All right, advance.
So, Bhaskar, does this feel like a soft plaque in this case, or is it feeling a little crunchy?
Yeah. I think it feels a little bit soft, but there are portions of it which I can feel the stiffness. So based on this, I think I just crossed the occlusion. And thankfully, this was an easy cross on a live case.
Yes, we're all grateful
Usually
for
it's
that.
not this easy. Yeah, and I think a lot of it is because, I do tell my staff it's what the patient brings to the table. If it's very calcified disease. And then, I've been doing this for the last 10 years, so I get a good feel of how things are. And then picking the right wire, the right equipment is so important. And, I was fortunate enough to train in New York, Mount Sinai, where we did, I think by the time I graduated, I did close to 1,200 interventions. So you get a good feel of these. So what I do is I have my catheter in the proximal left popliteal artery, and now I'm injecting dye to make sure I am truly in the right spot. So here I go. And that's the popliteal artery. You can see that.
That's great.
So
Say, Bhaskar, we just heard a talk about sleep and the health benefits of sleep. How are you coming on sleep, buddy?
Oh, sleep. Well, we had a STEMI at, what time was it? Yesterday? I think we had a STEMI which came from Custer. I'll need the long bare wire. Yeah. So we're just getting the right equipment. Yeah, so we had a STEMI around, I think it was 9 o'clock, 10. Custer, he was a tourist from Texas. Luckily, he recanalized and he's doing well. So he's going to get his angiogram this morning. And then in the middle of the night, I got a call from Dr. Heilman saying that we have to put a balloon pump in a patient with severe 3-vessel disease. So I've gotten 2 coffees in.
Yeah,
and
that's
also
good.
I apologize for the radiation equipment. There was some malfunction. So all this has definitely kept me going.
So your heart rate is above normal right now, I would say.
Yeah, my heart rate never goes beyond 60. I actually wear a Fitbit. Yeah. So can you guys see? So what I'm doing here is the plan is to put a filter in. So filter is a basket, and we'll show you when we get it in. It catches any thrombotic material. So that way it doesn't embolize into the foot. And before I do anything, and I'm sure you guys have heard, right? Nowadays, in treatment of peripheral arterial disease, using IVUS is very, very important. And that's what we're going to do. So can you guys zoom in to my hands? Yeah. So what I'm going to do is I'm going to put this wire, which measures 0.014 in diameter. I don't know. Can you guys see? You zoom it right there. Yeah. So that's the size of the wire. See, the idea is to keep it real small because you do not want to injure this artery. You want to keep it as pristine as possible. Now, the other question is, when do we consider these patients for bypass? I think right now we follow the concept of shared decision making. We see what the patient brings to the table, what are the clinical risk factors, and then what will be the best outcome. Obviously, with endovascular procedures such as these, we can get the procedure done in about an hour's time, and then subsequently the patient can go home the same day. You can see that's my wire. And I try to put it in a safe spot. And here I'd like to pick an occluded vessel. The reason I want to pick an occluded vessel is in case the wire does create some damage, it'd rather be in an unhealthy vessel. Did it move? Oh no, there you go.
Just be going out that side branch or something.
Uh-huh.
So right now we're looking at a view that's a still view, or are you showing us a live view?
Can you see the fluoro?
Yeah.
This is a live fluoro image.
Yeah. You can see my catheter move up.
Yep, we can see the wire now. Yep.
Yeah, there you go. So I'm bringing my catheter in position so I can put my wire in the right spot. There you go. So the wire just went into the posterior tibial artery, which is occluded. And then we're going to pull this catheter out. Go ahead, Marcy, walk this out. And I'll stay on fluoro. So we watch, make sure the wire stays there. So now we just kind of place this wire, which is called a bare wire. It is long in length. It's 315 centimeters. And then once this wire is in, we're going to put a filter on top of it. And this is a filter. We'll pull this guy out from this end. This wire, yeah.
You want to pull it out?
Yeah, out completely. So what I'm holding in my hand is a filter. It's basically a basket with a lot of mesh. So therefore it can catch something as small as, I don't know the exact number, but goes in terms of microns. So I feed this wire into a small port, and then this filter then rides on this wire like a rail. And then the plan is to place this filter below the infrapopliteal arteries, right by number 35, if you guys can see. That's the filter coming up, okay? Right there. I think that's a good spot to place it. So let's go off this mag up.
Yeah.
So just watch the fluoro. We're going to go, you can mag up one more. Let's go one more.
Sure.
So you guys can see that's a filter. Mag up one more, sorry.
One more?
Yeah. So what I do is I place my filter there. This is a red tab I pull out. And then there's a white tab here on my hand, right here. So what I'm going to do is I'm going to pin my black sheath and pull the white tab and watch to the floor of what happens. See, the basket opens up. So now that basket is going to stay there, and any work I do up top, we'll go with the IVUS.
Okay.
We'll use the 014.
Yep.
And so that basket is deployed, and it's going to be secure there. So the next thing I'm going to do is an ultrasound assessment. So what you saw earlier on, we did transcutaneous ultrasound. So transcutaneous ultrasound is through the skin, the regular ones which you get. This is a camera, an ultrasound camera, which I put inside the vessel to give me analysis of what's happening with regards to plaque morphology, vessel size. Is there any dissection? Is there any clots? So can you go to my presentation and just pull up that IVUS? Yeah, so what I'm doing, I'm just getting the camera ready. So
you want your slides showing? Is that what you said? There we go.
Yeah, there you go. So you can see. So that's it. We have two different kinds of ultrasound IVUS catheters. You have, this is the mechanical one where it points transducer that basically spins around and gives you a picture all around. It has a frequency going up to 60 megahertz, which means the resolution is high, but also has some other disadvantages. This is short monorail, some technical issues. The other one is made by Philips and a lot more easier to use, and you get it's a phased array. Okay. All right, now can we go to the ultrasound, guys? And you can go back to the fluoro. Yeah. So on my left-hand side, you see the fluoro. You can see that small little catheter there. That is the IVUS catheter. On the left-hand side is actually my IVUS catheter. The nice round black circle you see, that is the catheter. And the black, kind of which looks like a sandstorm, that is the vessel wall. And around it, this circle is actually the artery. So we're going to go through the occlusion. And as you can see, as I'm driving through this, you can see all the disease. So I'll show you what a normal IVUS looks like. Can you guys go to the presentation? Yeah, so on the left-hand side, it's the normal. As you can see, it looks nice and round. And then you have two concentric lines. That is the intima media adventitia. And the diseased is what you're seeing there. Hit again. Yeah. And that's what this one represents, the transducer, the guide wire, the lumen, the plaque, the media, intima, and adventitia. So, and as the title says, there's a lot of information we can learn. So let's go back live and see what's happening with our patient. So while I'm doing all this, my nurses are keeping a close eye on the patient. Show me the numbers in low mag.
Yes.
Making sure the hemodynamics are stable. Anesthesia ensures that, that the airway is secure, and so multiple people watching. Let's go live on the IVUS. Flush this, Marcy.
Yep.
So that's the IVUS currently you're seeing. My catheter in the middle. And that measures like, not a big vessel, like 4 or 5 millimeters in length. But also I see some spasm. So I'm going through.
Is this patient very tall, Bhaskar?
No, what's the height, guys?
No, I think she's 5.
And Alex, that's a good point to bring up because we need to learn how to treat, PAD in women very differently. I think we unfortunately use data which has been, validated in white men. I don't know if it applies to everybody. So there's my catheter going through the blockage.
Tell me when you want me to record.
Yeah, let's record, guys. Yeah. Okay.
Yep.
So would you expect
So
a 4
once-
millimeter vessel in someone like this, or would you think it'd be more like 6?
No, I think you would expect 5 to 6.
Yeah.
And also she's got a lot of disease, some spasm.
Yeah.
And unfortunately, because of tobacco abuse. So what I'm looking for here is I can see, that black space is disappearing. It's more thick, organized tissue. So you think a phoenix straight or an angle, 2-2? Probably do a straight. Yeah, also get a 2-2 phoenix straight.
Straight?
Yeah.
I have the deflectable.
So just based on this IVUS, it looks like it's a nasty fibrotic occlusion. There's some spots of calcium. Right there, it's completely occluded, you can see. And also I make sure my wire is intraluminal, which it is. And there it opens up, right, by 35, 36. Okay, stop. Perfect. So Marcy, measure the diameter. So what we do is with the IVUS, we also measure the actual diameter of the vessel. And based on this appearance of the disease, I've decided to use an atherectomy device. An atherectomy device is something which debulks. The one I've decided to use is the Phoenix. I've had a lot of experience with this, and doesn't embolize a whole lot, debulks.
Do you want me to do a whole?
Yeah, let's measure. Yeah, what is that measuring? 4.2. Okay, so it's measuring 4.4 millimeter in diameter. The other thing I do is I also inject nitro because I just put some wires and catheters, and it does go into spasm. So while we're getting this set up, so what Marcy is doing is getting the equipment ready. And Marcy, why don't you explain what you're doing?
I would love to.
Yeah.
So this Phoenix device is going to debulk, cut that plaque. So we are going to take, this is the catheter itself.
Can you guys zoom in? Yeah. Right there. You can see on the camera. Yeah.
Kind of hard to see.
There you go. That's the catheter. While she's doing that, can you pull up my Phoenix video? So while that is playing,
The catheter itself.
so this is a front load cutting catheter, and I'm going to show you a cartoon animation. Yeah. So that's how it looks like. It's on the wire. It's a drill, kind of drills through the plaque, and as it drills, it uses the concept of an Archimedes screw, and then it kind of sends all that stuff into the port and exit out. So therefore, nothing is left behind, nor is it embolized distally. Right?
I like how you
And
had to
in
throw
doing so-
Archimedes in there. Yeah.
I think that's what they use. That's the principle,
Yeah,
right?
it is. Yeah, I love it.
Yeah, it is. It is. So that's how the system works. And then there'll be and that's the device at the back, which has a built-in console, a battery pack. It's a lot easy to use.
Just go ahead and load it on the wire.
Yeah. And then I'll let them show can you show that side by side while I'm also doing the IVUS? Sorry, while I'm doing the Phoenix, actual Phoenix. Yeah, wonderful. So there's the cutter, and that's the disease plaque. You can see it rides up there and then starts to chew up this plaque. And we'll show you in live how we do it here. There you go. Starts to chew it up, break it up. And we've been using this for 2 years. Yeah, 2 years. Yeah. And that's what it does. Okay. So we'll go live. There you go. Oh.
So the advantage to that over some of the other debulking, the Silverhawk and all that, this is less
right. So,
trash downstream, I assume.
Yeah, it's great you brought this point up. Go to my next slide, guys. So I just submitted 4 abstracts to Link. If you guys know, Link is the largest endovascular meeting in the world. It's run in Germany. And one of the abstracts I'm submitting is on the use of Phoenix device in very complex calcified common femoral and popliteal artery stenosis, actually complete occlusions, which were turned on by surgery or not good surgical candidates. And we've done close to 51 of them with really good results. So I've really taken a liking to this device, but also we change depending on, so what we should do is take a roadmap here so they can see, test them. Right there, maybe a little bit higher up, right there. Perfect. Okay. Mag up there one. So it's between 18 to 32 is where we're going to drill. Yeah. Right there. Perfect. Right. Okay, so let's do roadmap. Yeah. So what I'm doing is I'm laying down the topography so I know where to cut this. And you can see that's the occlusion. My wire is across the occlusion. And so that's the profunda femoris artery where my hand is pointing. This is the SFA. And that's the skinny wire, the 014 wire right there. So I'm going to drill through that. Sorry. I had too much coffee, so I'm not able to keep it steady. All right, so I'm going to go in with the device.
Are you sure your heart rate's only 60 there, buddy?
Oh, you guys can check. My staff recognizes.
You put a pulse ox on you while you're doing it.
All right, so let's walk it back. All right, Marcy, let's put the breaker on. So what Marcy's doing, she puts the breaker on this wire. So
most every device we use goes over a wire, so.
Yeah. So Bhaskar, can you explain to the room why you go in the right leg groin to get to the left leg? Why do you do it that way?
Oh, yes. The reason is when you go retrograde into the common femoral artery, the risk of trauma injury is far less. Now, if I want to fix the left knee, the artery behind the left knee, some people go antegrade, meaning they go ipsilateral. But problem is you have to place the sheath in the direction of the flow of the artery. And it all depends on the body habitus, but generally antegrade sticks, that is basically accessing the artery ipsilateral to the lesion, has a higher risk of complications. Mm-hmm. You know, with this one, there's tens and tens of thousands of done. We have closure devices, and if time permits, I'll show you how it's done. And that's how we do it. So, but in some situations, complex lesions, I go. Yeah, great. Let's start. So we're going to start the machine. I do go antegrade. So my machine is running. I don't know if you guys can hear us. And then I'm slowly drilling through it. And what I do is I look, listen, and feel. I make sure the device goes in nice and easy. And if I don't like it, I pull it back. Because this device works as long as there's blood flowing into the lesion. And the sound's pretty decent. And Marcy's also holding the...
Yep, I'm holding the wire.
Yeah, she's holding the wire. And also she watches what's happening. And also at the same time, remember, we are cutting through this. We watch the hemos, the heart rate, or if the patient's in any kind of pain. And a tanner will let me know, and my nurses are also watching. So far, right here, you can see the sound. It sounds like it's trying to gum up, so I'm going to pin it there, walk it back a touch. There you go. And that sounds a lot better. And then I'm going to advance it further. I can feel there is definitely some resistance here, so it's probably getting into the plaque. But the idea is to give it some time, let it work. And you can see we've already crossed more than half the occlusion. And things are looking good so far. So while we finish the restraint, you want to say as a nurse, what do you look out for? What do you watch? What is your role here?
Mine is obviously looking at eyeballing the vital signs, and her heart rate's been solid at the 60s the entire time. Her blood pressure's fine. Our arterial line's damp because we're clear down in the SFA. But and then I'm anticipating other needs that the doctor might have, such as equipment, balloons quickly, stuff like that, another wire if it gets boogered up. So
Yeah, so everybody plays a role. So it's very, very critical. You can stop there. Yeah. So let's go off-road map and let's zoom in really mag in as much as you can. Sorry, that's me.
Yeah.
All right, mag up one more.
Sure is.
So I'm going to really zoom in. I don't know what mag is this?
It is 16 centimeters.
Okay. So now you can see the device there. You can see that as it's drilling through, and that's what it does.
So, Bhaskar, does that device produce enough heat or anything to damage the vessel wall, or is it not very hot?
There is some heat, and that's why we make sure we pull it back and forth, mag down completely and walk it out. Yeah. But I don't know the exact honest answer, but I'll ask my rep, Kritina. What do you think, Kritina? Do you develop a lot of heat? That there's some thermal injury to the vessel wall? Have you guys seen it? Yeah. So,
Hold on 1 second.
yeah. So we often, when we do these cases, we have the reps for this device. So we have a Philips rep. Kritina, you can turn it off. Yeah. Walk it out. Yeah. And I've also visited the lab in San Jose, and we actually looked at some animal models, and no, there is no injury at all. And they go through a very rigorous process. Yeah. Can you zoom in right here, guys?
It was kind of hard to see.
Can you? Maybe this is not English, or maybe a blue towel.
Sure.
All right, Rich, can you zoom in as much as you can on my hand or the blue towel? I want to show them. All right, really still.
There we go.
There you go. So that's how small the catheter is. There you go. Yeah. Okay.
It's the coffee.
That's a little difficult, but I'll try my best. All right. So, Marcy, why don't you turn it on? And that's the little drill inside, and it aspirates. Show them the port through which it comes out. Yeah. Little more. You bring right there. You see that blood coming out? So basically the plaque is all mushed up, and it through the Archimedes screw, it comes out right there. Perfect. You can stop.
That's great.
So the next thing, next thing what we're going to do is we got to take a picture and see that did we really open up a blockage or no. Or we also look for any complications. I don't foresee any just based on how things went. What number to number it was? So just to remind people, so here's that blockage. You can start roughly right by, you can see number 20, and the blockage then stops right by maybe 30. So maybe 18 to 30. So we'll focus there and see what's happened. Mag up for me one more. One more. Perfect. All right, let me make sure. So I aspirate the sheet, make sure there's no clots. Contrast. Perfect. So you have a DSA? I changed it, yeah.
Okay. That's tricky.
Yeah. So here's a picture. And you see the flow is a little restricted, but it's coming. And there's the flow. You can see the trickle of flow. And if you're not sure what it is, what we also do, the next thing is IVUS. And with this atherectomy, that's what I want to achieve. So now at least I've got some flow down there. So we'll do an IVUS. The atherectomy breaks up the clot and debulks the lesion. So the next thing we have to do is to make sure with the IVUS that there is no clot, which means the treatment will change. And I also want to inject and make sure that my filter, and that looks pretty good. Okay, so based on this, we'll use a serenator. So we have a 50120. Okay. So while we're pulling the IVUS up, can you go back to my slides? Just from the angiographic field, I am planning to use a special balloon called a serenator.
Grabbed one.
Right there. So that's the serenator balloon. And as you can see, the construction worker, the principle is when you have linear serrated ridges, these can deliver a significant impact with the same force. So therefore, you kind of create indentations into the diseased wall. And hence, when we use further therapies like drug therapy, it works really good and hence reduce restenosis. Go to the next slide. And those are those ridges. Sorry, those serenity ridges. Next slide. And I'll let you watch this video while we do our IVUS offline. And so, as you can see, that's the balloon. And go. Yeah.
Oh, yes.
And thus ridges open up, they zoom in, they dig deep into the plaque. One advantage of that is it does not cause vessel trauma. Some fluid.
Yes.
Yeah. So what this balloon achieves is with the least amount of inflation, you achieve the maximum benefit. And it has been phenomenal. And I know the gentleman who was responsible in designing this. He's Dr. Peter Schneider. He's a vascular surgeon. And I've talked to him, and it works really well, especially in such lesions and in below the knee. Right. And that's how as you can see, on the left-hand side is a regular balloon. See how it damages the vessel. This keeps the structure intact, reduces dissections, trauma. And when the balloon deflates, you can see a lot more luminal gain on the right-hand side with the serenator. On the left side is a regular balloon. Okay. Now we'll go back to IVUS, guys, live. So what I did right now is I put my catheter all the way down in the distal to the lesion. And now, live. Yeah. Record, yeah.
Yes.
So I'm pulling my catheter back. So right here is the blockage. There you go. So I can see I've created a lumen now, definitely. I don't see any clots, which is always a good sign. And perfect. You can stop. Yeah. So the IVUS basically told me, yes, I did debulk the lesion. I did not have a dissection. I did not tear the vessel wall. And I don't see any clots. So the next thing I'm going to do is do the serenator balloon. Now, let's open up 50120. What is this? 40? Oh, yeah, that's plain. So the 40120. 5040. Okay. Yeah. So we'll get a 5040. And that's the other challenges we have in the. Yeah, go ahead.
How often do you have to use the drilling device or the serenator type ridged balloon versus standard equipment?
So the serenator in our lab has been here for the last few months, but I think in trials it's been there for at least a good 3-4 years. But I would say mainstream. I think probably in the last year it's picked up quite a bit. Uh-huh. Yeah, so that's some of the advantages of that.
And how often do you have to use the drill or some debulking agent?
We use it
on... Yeah, so right now, my algorithm is if the vessel's calcified, if it's a long lesion, it's a CTO, then I definitely use the debulking device. So the data on that, if you look at some of the studies like the reality and so on and so forth, you reduce the amount of stenting. And that's critical because, in your leg, knee joint, behind that, you're walking, you're sitting, you're bending. You don't want to put any metal scaffolds, unlike what you do in the coronaries. So therefore, I try to preserve the natural architecture of the vessel as much as I can. And there's the balloon, right by 35. Yeah. So depending on the situation and the IVUS findings, I change. Sometimes I just balloon. Also if... how sick the patient is, mag up there? Mm-hmm. Or if I want to achieve a quick result, we have an acute limb ischemia, then sometimes we do what is needed to save the leg.
Go up there?
Yeah. And keep in mind, when you have a diagnosis of chronic limb-threatening ischemia, so you go up to, 4, and that's the balloon going up. And if you really zoom in, you can see the ridges. So once you have a diagnosis of chronic limb-threatening ischemia, the risk of having serious events as well as mortality is very high. In fact, your chance of being alive, when you've been diagnosed with CLTI at the end of 5 years is as low as 30%. And unfortunately, it is, the only other disease worse than that is pancreatic cancer and lung cancer. So right now there is a very strong movement. And I think thanks to people like Dr. Pollock, who've been very, very instrumental in letting the government know that we need to drive, more research, more awareness about this. When you have an acute STEMI, your mortality is 1 to 2%, but in acute limb ischemia, it's as high as 12%. So we definitely need to do a lot more. Down. Yeah.
And they're dying of strokes and heart attacks, not from their leg, right?
Exactly. You don't die from sepsis, you don't die from renal failure, but your main reason is you die from an MI or a stroke. Just having asymptomatic PAD. So if you look at the partner study, when they went to family practice clinics, close to, and there's the balloon opening up. It opened up the blockage real nice. I see the balloon well placed between the wire equally. That tells me it's a very good inflation. In the partner study, so more than 25 to 30% above the age group of 70 had asymptomatic PAD. And if you add smoking and diabetes, the rate is a lot more higher in patients even at the age of 50. And their risk of mortality is 3 to 4 times higher. So therefore, risk factor modification, lifestyle changes is so critical. There are some other studies trying to recognize whether these patients should undergo aggressive coronary ischemic evaluation. Yeah. There's been some small center studies, but nothing in the large scale. Let's walk by. I think it's
45.
Yeah, I think it's all the way to 2018 or something. Yeah, right there. So those are the things which we keep in mind. So obviously, once this patient is treated and taken care of, what we plan to do is, optimize the medical therapy. Then she'll be followed up very closely in our clinic, making sure medicines, surveillance ultrasounds, risk factor modification, and often have seen after we treat their claudication, a good number of the patients start to report of angina and chest pain. So it's important to recognize them. Unfortunately, being where we are, we're really plagued with CLTI. That's good. We'll go up there. Very, very adversely. If you look at the WHO statistics, it's unfortunate our Native Americans are very disproportionately affected with this disease. And they have the highest rates of amputation and mortality for any first world country. So clearly there's a lot need to be done. Down. Yeah. And as you can also see, it's reflected in NIH funding for study of indigenous health has definitely gone up. If you look at the ACC documents, there is absolutely no data on Native Americans, especially in this region. If you open up the primary prevention or document, it basically says dash.
Right. Yeah, the Strong Heart study is one of the bigger studies we've done here, but there needs to be more.
Yes. There needs to be more dedicated. I agree. So we just finished ballooning. So we're going to take a picture and see how our flow is. So it's a very methodical approach to this disease. As you can see, I did an IVIS. I found out what it was. I know this lady has bad critical limb ischemia, so I got to get in good blood flow. I said 18 to 30, right? Yeah. All right. So let's go 7, 4, 12 or something. And we'll take a picture for you.
Right here that injects our contrast.
Yeah. So much, Marcy. So this is an assist device. Ready, Marcy? We're going to inject and we'll see the flow. And I don't know if you guys see the difference. Yeah. So we got that blood flow opened up really good. So
you're getting a round of applause, buddy.
Oh, good to know. Thank you. I think it's a teamwork here. Yeah. And I'm very, very grateful. But also, I'm not very happy with the way it looks. It's it has a complex dissection. So, unfortunately, I know even just with a drug-coated balloon, I won't be able to fix it. So I will have to place a stent. So the stent will be from number 20 to
So Bhaskar,
32.
Do you think we should let you work for another 15 minutes and then come back to you, or do you want to stay on?
I'll show you the stent. Yeah. So let's get a 6 or 120 alluvia. Or you guys can do that too. Yeah. I'll get the stent placed in and I'll show you, or I'll show you right now. Go ahead. Open up the stent. So what we're doing is a special kind of stent. It's It's made by Boston Scientific. It's called drug-eluting stent. In fact, there are only 2 drug-eluting stents in the lower extremities. One is Zilver, and this is Eluvia. And they did a head-to-head trial, and Eluvia did a lot better. So that's the stent. Marcy, you want to show them?
I do.
Yeah. Okay. Yeah, we'll just check. So my nurse just told me to check how the blood levels are doing. Make sure it's thin enough because we have a catheter. So then, can you guys zoom in? Yeah, so that's the stent. It's harbored in that catheter. And then we deploy it with the wheel. So anybody in the audience have any questions or?
Yeah, do we have any chat questions
critiques?
or any other audience questions while he's getting ready?
I would also love to hear from Dr. Pollock what she thinks and her opinion is.
Come on, Amy.
All right, so we're going to show you. We're going to be deploying the stent here. We'll take a quick picture and then you guys can go away for a talk and then.
I have to break that.
Yeah. So there is something called the new thing. You can pull the yellow tab off. Yeah.
This one.
No, other yellow tab. Yeah.
So Dr. Pollock has the mic right now. I'm not sure what she's going to ask.
Oh, no, I was just going to comment. I think you've done an outstanding job, and it really loved how it's not only just focusing on the procedure, which you're doing an extraordinarily just excellent job with, but just also just the education about PAD. And I loved how you were tying it in with the risk factors and the importance of treating PAD to prevent heart attack and stroke and that acute limb ischemia. We were talking last night that a lot of times we'll talk to patients about it being a leg attack. Because acute limb ischemia or chronic limb-threatening ischemia, although we all know what that means, it can be kind of a mouthful and a lot to process. And so I think kind of that language for how we talk about it with patients. So no, you're doing a fantastic job.
Thank you.
No, thank you. Thank you. And then I often say that as an interventional, I call myself a glorified palliative doctor, because if you truly see what I'm doing is I'm just pushing the plaque aside, opening up the blood flow. So I just deployed the stent. I don't know if you guys just saw, and Marcy's walking it out. I'll get a 600 nanocross or 6 balloon. So what I'm doing is essentially pushing all the plaque to the side. I'm not doing anything to alter the natural course of the disease. And what that does is done by medicines, lifestyle changes, and it's so critical. So I hope we have a recorded version of Dr. Pollock's talk. I really want to watch that because I think it's not only useful for you, but also for your patients, but most importantly for the young generation. You know, we've seen that with ultra-processed foods, and there's been some evidence that your consumption can be as high as 25, 30%, and cancers are more common. So I think it's a great lecture. So we have the stent placed. Let's zoom in on the stent. We'll show them what the stent looks like. Yeah, there's the stent. We'll go to Cine.
Hold on, let me center that a little bit more.
And yeah, there's the stent. So I'm zooming on the stent, and that's the metal scaffold. So this metal scaffold has a polymer. Yeah, what's this? Yeah, that's fine. Yeah. And this metal scaffold, as I say, it has a little polymer, and the polymer lies a drug called paclitaxel. And this drug is eluted into the vessel wall. And what it does is it prevents scarring and restenosis. Because if you think of it in a crude way, what I just did was controlled iatrogenic injury. So now to prevent restenosis, rescarring, I therefore have to deploy this drug elution to prevent further restenosis. So what I'm going to do is I'm going to do a quick touch up with the balloon, and we'll take a picture. And after the picture, you guys can go away for a talk, or I hope you guys got a coffee break there.
You need a coffee break, I think. So one of the questions that I got to my phone was, when you do this procedure, because they're able to ambulate, is that actually going to decrease their mortality long term because now they can exercise?
Yes, that is so true. Actually, honestly, Alex, I didn't think about that point. Yeah, it is. In fact, we asked them to take it easy for a couple of days, and after that, walk. And that's why if you see the most recently updated guidelines, focuses so much. So we'll just go very gentle, not to open it up. That's it. Focuses a lot on appropriate medical therapy, healthy lifestyles, and even in claudication. Like this patient tried for a good 7-8 months of structured exercise therapy at home. Unfortunately, she works in the local school. She's a paraprofessional. That's plenty. Perfect. Done. And she could not keep up. She had to climb a flight of stairs or two. So Jen, what we'll do is we'll get ready. We'll measure the pedal acceleration time and show them the difference. Yeah, you can walk it out. Give me 1 second. I'll take a quick picture here. I know. Remember, we're doing all this with a little filter down there, right there. So this filter catches any embolic material, prevents that going into below the knee. Right? So
I love how Marcy is following exactly what you're doing without actually saying anything. Marcy just knows what she's doing.
Oh, yes. I'm very grateful to my cath lab team. They put up with me. And when I joined here the last 9 years, I know they're all giving me the look. I keep them long hours here, but the work has to be done.
So true.
Hold on 1 second. Just got DSA. Yeah. And obviously, I cannot thank my wife enough because she manages the kids and puts up with me so I can be here and take care of patients. So this is a angiogram, and now you can see the flow there.
Very nice.
Better.
So this is what we are finished with. And that's the finish. And we'll keep that there, and I'll show you what we started with for you to get. Is there a... We can't do but you can take a look at the pedal. Yeah. So this is what we started with, just for you to give a reference. That's the blood vessel we started with. This is what it looked when we took the initial pictures. And obviously you saw the finish. And next, what I'm doing is, the big question is, should I go fix more? How do I objectively assess that? How do I know this is enough to get rid of for pain? One thing is you can leave it alone, let the patient rehab, come back and see if it helps. But if it does not, you can go back and fix below the knee stuff. The other option is sometimes I do pedal acceleration time. And I'll take a picture of the filter right there. Yeah.
ACT 372.
370? Okay, good. Marcy, let's take a picture of the filter. Good. So that's the floor down below.
Better.
So now we'll take the filter out. Yeah.
You have a little spasm right down there, you think? Or
yeah, it's spasm. Yeah, we'll give some nitro after this. Right. Let's switch to the ultrasound, guys. Yeah. So you can see right now on the ultrasound, the flow is a lot better. Not the ideal. And often, if needed, I will probably go and work a little more and try to get that opened up. So if you guys want to go away for a talk, you guys can go away. And maybe you can come back for like 5-10 minutes later on to show our final finish.
Yeah, we'd love to do that. If you want to just hit us with a text when you have something.
Yeah, sounds good.
We're going to do Dr. Hernandez next, and we can always interrupt him because we don't really care if he gets interrupted.
Oh, yes. All right. Thank you. We'll see you guys soon. Bye.
All right.